right, well, thanks for the invitation to speak. We'll go through this sort of lesion here. Here are my disclosures. Just the timeline of endovascular technology for ISR, starting with bare metal nitinol stents, certainly an advantage over angioplasty alone. Drug-eluting stents with a greater than 40% relative risk reduction in restenosis with Zilver PTX was another major advancement in the mid-2010s. And now drug-eluting stents and bare metal nitinol stents are certainly at risk for stent fracture and in-stent restenosis, and those issues are now well recognized. But despite advances in self-expanding stents, the incidence of femoropopliteal artery in-stent restenosis ranges anywhere from 15 to 32% at 1 year. Certainly we've heavily depended on paclitaxel, but exciting new advances in our ability to use mTOR inhibitors is coming. We've mentioned the Tosaka classification, but certainly it does seem to matter based on total occlusion versus focal or long non-occluded lesions as far as the patency for femoropopliteal in-stent restenosis. From XLPAD, another nice, fairly contemporary experience looking at femoropopliteal restenosis with 347 in-stent restenotic cases compared to non-restenotic cases in the femoropopliteal segment. Relative to non-in-stent restenosis cases, there were fewer treated chronic total occlusions and severely calcified lesions. Atherectomy and drug-coated balloons were not surprisingly used at a greater rate, and the in-stent restenotic lesions and in-stent restenosis was associated with higher rates of repeat revascularization, but not all-cause death or major amputation. There have been two primary studies of in-stent restenosis, kind of intentional for the femoropopliteal segment, including DEBATE ISR, which really kicked off a journey for drug-coated balloons in the femoropopliteal segment in the FAIR study, and certainly seemed to be a lot of advantages leading to enthusiasm for drug-coated balloon angioplasty, particularly for ISR. We, of course, compared these results to a couple sample studies, including IMPACT SFA and RANGER 2 SFA, which also show advantages for drug-coated balloons over angioplasty alone, though not exclusively for in-stent restenosis. Stent grafts for in-stent restenosis include the RELINE randomized controlled study looking at covered stents to create a mechanical barrier to prevent the egress of hyperplastic growth. Perhaps we can talk to this about this case here with that stent overlap issue, but in any case, treatment of long segment disease, perforations, and aneurysms certainly can be an issue in some of these cases, and a major limitation of devices is the increased risk of stent thrombosis when these grafts go down, as well as coverage of collateral vessels, particularly in the popliteal segment. The Viabon endoprosthesis is the only FDA-approved covered stent for the treatment of symptomatic femoropopliteal disease with a nitinol frame and heparin coating. And in RELINE, 83 patients with SFA ISR, Rutherford 2 through 5, 8 sites randomized 1-to-1 to Viabon versus angioplasty. Primary patency at 1 year was 75% versus 28% with angioplasty. I think Kumar is going to talk about PTAB, but certainly this is a new and exciting treatment option. Here is a table of some of the studies kind of looking at detour 1 and detour 2 relative to conventional bypass. I've listed bypass on the top, just a contemporary review of autologous venous femoropopliteal bypass with a 1-year endpoint in that study of 129 patients at 69%. Infrainguinal autologous venous bypass in a larger study from 2016 was similar at about 66%. PTAB and Detour 1 and then a larger Detour 2 experience was pretty good at 1 year with 72% patency in the larger study. The primary patency was not listed in Dr. Leiden's talk at 2 years or the publication that followed, but primary assisted patency was 69% at 2 years. Many of us rely on these data to support our use of laser atherectomy for ISR. EXCITE ISR was 40 centers prospective randomized study looking at Rutherford 1 through 4 enrolled in the early 2010s with ISR lesions in a target vessels greater than 4 centimeters in lesion length and in vessels greater than 5 millimeters in diameter. And this was endovenous laser ablation plus angioplasty versus angioplasty alone, randomized in a 2-to-1 ratio with target lesion revascularization as the endpoint at 6 months, and then a safety endpoint of major adverse events at 30 days. Endovenous laser ablation plus angioplasty was superior, and the freedom from TLR was 73% at 6 months versus 51% compared to angioplasty alone. The major adverse event rates were actually higher for angioplasty than they were for laser. Cilostazol is kind of interesting. This is data from Terumo and the use of the Masago Stent Japanese study. 270 eligible patients randomized in 3 different groups. 85 received the Masago self-expanding stent without cilostazol, Masago with cilostazol, and then a Zilver PTX without cilostazol in a DES group. Masago, of course, being a bare metal nitinol stent, and all 3 groups were studied out to 1 year, and you can see the Kaplan-Meier curve for patency on the right there. And there was no statistically significant difference in the log rank of the groups, of the 3 groups. So the future of drug-coated balloons, as I alluded to earlier, is exciting because certainly we've relied on paclitaxel and its lipophilic qualities to get the job done. But as we've learned in the coronary space, the mTOR inhibitors certainly seem to be better. And so there's new drugs, excipients, nanoparticles, as well as dosage and DCB delivery optimization that's ongoing. And I think this is really going to refine how we use DCB technology into the future. We alluded to, I think Dr. Garcia mentioned the SCI appropriate use guidelines earlier, and this is just a sample of the specific guidelines to in-stent restenosis, and really the only appropriate classification was for drug and for laser atherectomy based on Excite ISR in that guideline. My algorithm then is to first define the lesion, consider the clinical indication, history of recurrence, risk of surgical revascularization. Certainly surgery should be considered in patients with in-stent restenosis, just like we do in the coronary space. But assessing lesion length and severity and the consequences for both surgery and endovascular revascularization should be considered. And then kind of the universal use of IVUS to evaluate ISR, just like I use in my coronary practice. Then is to prepare the lesion, pre-dilate, high pressure, address the mechanical factors, whether it's malapposition, dissection, stent separation, and in-segment restenosis. And then I tend to use more laser atherectomy, although certainly have used Rotarex in my practice as well, but generally rely on laser atherectomy. And then treat with deliver drug, reassess and optimize results with IVUS and angio, and then consider cilostazol, especially if the patient does not have heart failure. So to conclude, at 1 year, incidence of femoropopliteal ISR remains about 15 to 30%, depending on lesion characteristics, drug-coated technologies, with or without laser atherectomy or other forms of atherectomy, plus or minus cilostazol, have the greatest evidence against in-stent restenosis. And advances in anti-restenotic drug delivery and development are likely to reduce further the rates of ISR relative to contemporary therapies. Thank you.